Hi, welcome to My Favorite Mistake. I'm your host, Mark Graben. Our guest today is Dr. Edward Feinberg, a distinguished expert in restorative dentistry who's dedicated over 40 years to advancing dental care. Dr. Feinberg graduated from Tufts University, was then trained by his father, Dr. Elliot Feinberg, who is a pioneer in full coverage restorative dentistry. He practiced in Scarsdale, New York, before moving to Arizona, where he continues his work. Ed is the director of ONWARD, an online teaching organization for full coverage restorative dentistry, where he's created over 30 courses and has a lot of educational resources there. He's a nationally recognized lecturer and author. Ed has contributed significantly to the dental literature, including his essay collection, the book Open Wide, Essays on Challenges in Dentistry to Achieve Excellence. He also serves on editorial boards and councils for various dental associations, and has been honored with numerous awards for his contributions to the field. So, Ed, welcome to the show. How are you?
I'm fine. And you? Thank you.
Yeah, I'm doing great. We're going to focus on the topic at hand. I'm not going to think about, are you evaluating my teeth? I'm not going to do that through
the way we're trained, that's the first thing we notice whenever we meet people is their teeth, because that's how we're trained.
Yeah, I don't have too much to be self-conscious about here, but if there were, I would certainly go talk to my local dentist. And we're going to talk about some of the trends and your thoughts and data around some of these trends in cosmetic dentistry. And it would be interesting to explore that as our first dentist to appear here on the show. But as we always do, I'm going to ask you, Ed, the key question to kick things off. What would you say is your favorite mistake?
Well, my background is such that I can save a lot of teeth that most dentists are extracting. My approach to saving teeth, for example, that are flush with the gum, is completely different from what's being taught. So I don't build them up with posts or build-ups or anything like that. While the entire profession is focused on concentrating on the tooth structure that's above the gum, I couldn't care less if there's any tooth structure above the gum. I care about what's below the gum. And I make all my crown and bridge to fit precisely so that I let the patients wear the dentistry on a trial basis with rubber or Vaseline, and the crowns do not fall out. So this is what I teach, and this is what I brag about. So I had a patient, my dentist buddy from Brooklyn, and he came all the way up from Brooklyn to Westchester to see me, and I made a crown for him. And guess what? It fell out, and I was mortified because it was the person I wanted to impress the most. So,
What do you think, was that the first time that had happened, or it was just very, very rare for you and your
no,
patients?
actually, it happened before, but there is always a reason when something goes wrong. And if you can identify what the reason is, you can correct it. So I looked at it, and then it was obvious to me what the problem was, that I didn't get enough grip on the root. So it didn't fit tightly enough because of that. And that was that is almost always the reason when something like that happens. So I wouldn't even look at it. I would just do it over. So I had to do a little bone work, and then I was able to make him a crown, and I let him wear it with a Vaseline ointment until I was satisfied it was perfect, and then I cemented it in. That's how I do dentistry in general. And very few people know how to do that. Very few. There's an absolute epidemic of extracting teeth like that to put implants in. And that's happening all over the place. And I think that's wrong. I think teeth should be saved first. And putting a single tooth implant in among other teeth is usually a piecemeal approach to dentistry. Except, let's say, if all the teeth are in perfect condition and there's no periodontal bone loss, that's a perfect place for an implant. So you don't have to touch any of the surrounding teeth. However, when you go to the lectures and you go to look at the published articles, that is not what you see. You see teeth around the space with big fillings and crowns, or they're going to need crowns. And that patient would be better off served with bridge work, where you can do something good for the entire area, and that's the end of the patient's problem. So if you know how to do good
Yeah.
bridge work, which is what I teach, you can correct the architecture and change it so that it doesn't put deleterious forces on the periodontal bone. You can bring the forces up close to the bone. What I mean by that is when I'm finished, I always take finished x-rays, and you could see how the crowns look like they're sitting on the bone. And that's to prevent future periodontal problems. That's usually the end of the patient's problem. A single tooth implant only fills a space and does nothing for the teeth around it. So the patient's problems are never solved. And most dentists look at crowns and bridges as nothing more than tooth coverings, when they should be looked at as corrective dentistry. So I don't want to make it sound like I'm against implants, because where they're indicated, they're a great restoration. But I'm against their overuse and inappropriate use, which is what I see rampant in my profession.
Mm. So it sounds like you're saying a lot of the profession is making a number of mistakes in their approaches and with their patients. And I definitely want to dig into that, and I think we can come back to that. And if you help me understand some of that in layman's terms, somebody who sat in the dental chair, but not for all of these different types of procedures. But if we could add, maybe kind of go back to the story, I'd like to close the loop. We were saying that mistake with the crown falling off, and were you able to put some checks or, if you will, mistake proofing in place to make sure that you didn't repeat that mistake then with future patients?
Yes, well, I have a step-by-step protocol so that if an error occurs, you identify what it is before you go on to the next step. So you know you're going to have a perfect result. But I'm a human being like everybody else, and sometimes
Right.
you
Right.
miss something. And then when you have a problem, usually it's obvious what the problem was. And so I look at failure or mistakes as a learning opportunity, because I want to know
Right.
why. And if I can find out why and correct it, then I'm not so upset about it, because there's a reason why that happened. And then, of course, you can prevent that from happening on future patients. So there are a
Yeah.
few times where you can identify what a problem is, but that is really rare. I think most of the time you can pretty much figure it out, especially with technical issues, which is like what this is, a technical thing,
Yeah.
mechanical, and not really things that we don't understand. Like there are things that cause periodontal bone loss that we don't fully understand. So there are some people who are genetically predisposed to it, but they're in the small minority. I would say most of the time we can identify what the problem is and correct it for the patient so they can hold on to their teeth.
So in my life, I've had, I think, two crowns, and I think I was concerned that the temporary crown would fall off, because that were and then you would have is this correct to say part of the tooth still remaining that the crown's been attached to, or is that attached to what you would call
Yes,
the
oh,
bone?
absolutely. So I know how to make temporaries with copper bands that will fit like permanent restorations and do not fall out. So when I'm
You
dealing
said
with,
there's a band around,
yes,
like holding it
it,
on,
they're like
not
copper
just
tubes. Yes, it forms a retention, so it goes under the gum and grips the root like the permanents do. So it fits like a permanent
Mhm.
restoration. So I make a lot of those,
Mm.
because one of the things you don't want is the patient to be unhappy with temporaries falling out, or the teeth start to
Mhm.
rot. You can't wear temporaries forever. But the temporary with the
Mhm.
copper band, I've had patients not come back for 4 years, and the teeth were clean as a whistle underneath, and I was able to finish their
Mhm.
case. That's what copper
Mm.
bands can do,
Yeah.
and for two reasons. One is copper is extremely antibacterial. There have been studies
Mhm.
that show that there's zero bacteria on copper, unlike other metals. But the real reason is that the crowns are modeled on the model of the mason jar cover, which is the best known thing ever devised for food preservation. So this is not taught in any dental school, but comes from the roots of dentistry. My dad's teacher did this. And somewhere along the line, the dental schools went off the track because I really believe they wanted to teach techniques that were easier for the students. And because they have to graduate with something when they get out and to be able to do something. But they neglected to tell them that that's not the only technique or even the best technique, and that your education really starts on the day you graduate, and it's up to you to continue your education. So they forgot that part. And so now that's become like an indoctrination, and everyone in the country does it that way. And they're all having troubles with problems that have been solved in the 1930s. And that's very sad.
Because, I mean, you would hope as a patient or a member of the public that the techniques and the education is only getting better over time. Like, I think in like the medical realm, nothing life-threatening, thankfully, but a couple of times where I was given a different opinion by a younger surgeon who seemed to have the more recent education. Like I had a badly herniated disc, and one older surgeon who did a ton of back surgeries, he said I needed back surgery, and then COVID happened. So there was a delay, and I moved and got a second opinion. And this was I think a relatively fresh out of school doctor. And he actually gave me the journal articles that showed, what they're teaching us now is not rushing to surgery leads to better outcomes than immediately rushing, maybe is a judgmental word. But, I think, it's interesting to think, well, okay, younger doctor, more recent education, the other surgeons have an obligation, I guess, to keep up, difficult as it is. But I guess the point of my long story there was that your opinion is that dental education is not getting better and teaching the best methods as we progress through time.
Well, this is my area of dentistry. Other areas of dentistry, like endodontics or orthodontics, have made huge strides, and it's so far superior to when I graduated. But not my area of dentistry. It's gone backwards. And a lot of the technology that they've invented seems like it's an improvement, but it actually violates the basic principles that allowed my dad and I to have so much success. So I have 70 years of documentation, more than 100,000 pictures of crown and bridge cases that go back to 1950. All the teeth prepared and handled the same way, and the cases followed for decades with x-rays. Nobody I know has that. They can't show that. So I can show cases that I did in the mouth 30 and 40 years with very few changes in the periodontal bone. It's a completely different philosophical approach. And I have trouble reaching dentists about this because they're so indoctrinated in a way of thinking that they're not open to new learning. But you brought up a good point.
That's troubling.
You brought up a very good point about doctors in general. See, getting second opinions is important. Like in dentistry, we're not all the same. And if someone can't save your tooth, maybe another one can. So people don't seek to get second opinions usually in dentistry. They just accept whatever their dentist tells them. But they're very quick to get a second opinion in medicine. And there are a lot of doctors who want to do a case, which is not fair. I always try to do what's right for the patient, or try to figure out what is the best treatment for that patient, given all of the things that I know. And what is the least invasive? It's not just the money, it's also what you have to go through. And what has the best track record, so that you could recommend the best treatment for that patient. So a lot of dentists, they're looking at patients like dollar signs, and they want to do a case. I mean, that happens in medicine too. And the poor patient could pay a big price for having surgery, and it doesn't always go the way they say. At least dentistry, no one dies, thank God.
Yeah, I mean, there could be pain. A lot of, I haven't had anything, thankfully, dentally. Everyone tells you how bad a root canal is. Having my wisdom teeth out was probably the most painful thing I went through from a dental perspective. But going back to the situation with my back, that second opinion came from somebody who was trained to do the surgery. I mean, I wasn't seeking, and that's the thing that was fascinating. I wasn't seeking a second opinion because I wanted that second opinion to be different. It was really out of necessity because of COVID times and where I was. And I wouldn't leap to say the first. I mean, I think the first surgeon was well intended. But it's tough when the doctor can say you need surgery, and the reality is they are going to make money off of that. The second doctor who said it's actually better to wait, again, he could have done the procedure, but in a way, I mean, yeah, he was
So that's a good
in our
doctor
US based
because
model, he was giving up
he
income.
put you first. So he's a good doctor. And they should
I
put you
appreciate that.
first. And I had to go to a heart
Yeah.
surgeon, and I didn't need surgery, thank God. And so he said to me, "You don't need surgery." And I said, "Well, don't worry, you'll make it up on the next patient." Because that's how they make their money, is by doing these cases.
Yeah. Well, and that's a episode for another day with a healthcare economist or somebody who can, talk through these different models of how do we incentivize and reimburse people based on keeping us healthy instead of just reacting to the problem. I'm sure that back surgeon was good at doing the back surgery. That's not the issue there. It comes back to your point of should we be removing the tooth, not how effectively do we do it,
Yes,
right?
because implants are not panaceas. People think that, they're going to work perfectly. That is not true. You don't always know
Mm-hmm.
what's going to happen. And I've had the patient where the implants failed after 20 years. They're not lifetime either. So I think it's
Mm-hmm.
very important to put everything in perspective. And that if you can save the patient's teeth first, that is the best technique. And also, let me tell you something else that I've seen, because there's a lot of things I don't like. I also, in addition to giving a lot of continuing education, I take continuing education because I want to see what they're doing out there. And I don't know everything. I also want to learn. So I went to one course. It was a video from a well-known institute. And the professor showed the original x-rays, and I could have saved all of those patients' teeth and not put any implants in. I have options for patients, more than what most people have, that they can offer their patients. And the only time I ever push patients into doing implants is if they have no lower teeth, because the worst restoration in dentistry is the lower denture, because dentistry doesn't know how to make a good lower denture. The muscles of the tongue and the cheek continually lift it up. So for those patients, the only hope is to do some implants. But that's the only time. So anyway, I went to this course, and it was clear I could have saved all of these patients' teeth. They weren't that bad. Oh, that's not what they did. They pulled out all of the teeth, all of them, upper and lower, and they put 4 implants on the upper and 4 on the lower, which is what they call an all-on-4 case. And the implants weren't put in deep enough and at funny angles, which means they're taking forces that are not along their long axes. And then they screwed in this superstructure immediately, which is not what you're supposed to do when you handle implants. That's experimental and not normal protocol. And then they show the finished case, and the aesthetic result, and no follow-up. So you don't have any idea if that case actually worked. So I have all these young dentists sitting in the audience, and I got up and I said, "This is malpractice. Would you want that done to you?" I said, "I could have saved all those patients' teeth for him, and I have to go through all this invasive stuff." And let me tell you, that's likely to fail because implants are feats of engineering, and they're subject to all the laws of engineering. So, like, let's say, for example, you want to build a bridge across the Hudson River. and you don't put the supports in the ground deep enough, that whole thing's going to collapse because it's not designed to carry that load. That's exactly what happens in the mouth. So if you put these big superstructures on these implants that aren't deep enough to support it, you're going to have an engineering failure. That is so common. And when the all on four cases, they have to flatten the bone. So when the implants go, the patients might not be candidates for new implants. And then the ridges have been ruined, so they can't even wear a denture well. Then they're really screwed. So I'm against that.
Yeah. 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 And I mean, I think it's interesting when it's situations like yours or, hospital settings where people have developed methods that in a lot of cases don't just reduce but eliminate hospital acquired infections. They have methods, they have data, they have better outcomes. There was a guy I met, a surgeon, a cosmetic surgeon, who worked in the Dallas area, and he had better methods and he studied his own work. He actually did video study of his hand movements, and his goal was to not to rush through a case, but to be efficient in his time and motion. He was going straight out of industrial engineering basics because it was better for the patient to be under anesthesia a shorter time. There was easier recovery, less pain. He was efficient, but he struggled to find surgeons who believed his outcomes were that good. And he struggled. He did find some surgeons that would come and observe and learn his methods and could care for patients and be really profitable. So
It's a
I guess the
kindred
question
spirit.
back to you, Ed, is,
I'd love to meet
I'm
him
sorry.
because it sounds like he's a kindred spirit, because this is exactly what I have.
Yeah, well, that's why you made me think of him. Now, I think he did pass away. I haven't been in contact with him in a while. He retired, was up in Montana. I do believe, sadly, that he's passed, and his work and his method, does live on in some surgeons. But I was going to bring that story back to a question for you, Ed. When it comes to influencing people, like it's sad to say that data and evidence in medicine isn't enough to convince people to change the way they had been doing it, admit that there could be a better way. It's said in medicine it can take 20 or 30 years for a good idea to spread, and that's been true for a long time. What are your thoughts around some of that challenge,
Well,
or what
that's
we can do
exactly the
about it?
same in dentistry. I have
Mhm.
lots of people who take my courses and then they go back to doing the same old thing. Very few actually become excited about adopting a new philosophical approach. There's a big emphasis now
Mhm.
on economics and workflow rather than science and treatment.
Mhm.
No one talks about outcomes and longevity and case longevity, which is what I have to show. And that is
Yeah.
scary to me. That's not how it was in the beginning when I started in practice. In fact, I'll tell you, I wanted to be a mentor, both either in New York or in Arizona, to someone and teach them everything I know. Do you know I cannot find anyone who wants a mentor? Think about how awful that is. It's the
Mhm.
attitude of the current generation. They're more concerned about not everybody. I don't like to generalize,
Mhm.
but
Well,
a lot of them are forced to
but
think
it's
about
hard.
economics. They get out of school with debts in excess of $500,000, and they're
Mm.
supposed to be concentrating on building their knowledge and skills when they graduate because they're rudimentary. That dental school can only
Mhm.
give you a basic foundation, and that's it. And instead, they're forced to think
Mm.
about how they're going to pay back these loans. It's not fair. We didn't have that. It wasn't so expensive
Yeah.
when I graduated. So I think this is wrong.
Yeah. And does that lead to one thing we talked about when we chatted before? Um, was a trend, it seems, of more dentists shifting away from classic family dentistry. I have a friend in Florida who converted a practice from this family dentistry of lots of cleanings and that routine every day to doing a handful of implant cases every day because it's more lucrative. And it comes back to this question. I mean, I hadn't thought about this until you raised the issue to me of, the assumption was, well, I guess there's a lot of people now who can benefit from implants.
Oh
And
yeah, I'm not
you're
against
questioning that.
implants. I've done a lot of them.
No,
I'm against their
but the
overuse
overuse.
and their inappropriate use.
Yeah.
You know,
And,
this is what happens. There are a lot of people who can do good implants, and there are
yeah.
very few who can do good crown and bridge. So in their mind, they're like what I would call one-trick ponies because the answer to
Mm-hmm.
everything is implants, and they
Mm-hmm.
stretch it beyond
Yeah.
the limitations of what it's designed for. And that's
Mm-hmm.
why a lot of people get into trouble because they don't all work
Yeah.
the way they say. And some people have poor
Yeah.
anatomy, and you can't put good ones in. If you can't put good ones in, they shouldn't be done. You're just going to have a failure.
Mm-hmm. Now, does this lead to malpractice cases or a dentist getting in trouble with an insurance company? I mean, what are some of the
Well,
outcomes other
it
than maybe
it can. I
unhappy
mean, every case
patients?
is different. It can. Um,
Mm-hmm.
you know that a lot of people, they do what they know, and if that's all they know, everyone's going to get that. So you
Mm-hmm.
can't accuse somebody of that, of
Yeah.
wrongdoing, if they think they're doing what they think is right, but because they only know how to do one thing, they can't see the overall picture. So I like to call, like,
Yeah.
implants, the way they're being used, a piecemeal approach to dentistry, because it's just to fill a hole or a
Mm-hmm.
space. What we really want is someone who has an overall approach to dentistry, so that you get rid of all the problems and then you can maintain the patient, and they're done with it, instead of having things
Mm-hmm.
happen year after year after year. Their problems are never solved and they're always dealing with something.
Yeah.
That's not fair, I don't think. I wasn't trained that
Yeah.
way. I was trained to look at patients from an overall point of view. That doesn't necessarily mean you have to do all the
Mm-hmm.
dentistry at one time, but you should have a plan so that one day when you're done, they have an ideal result, as if they did everything all at once. You owe a lot of
Right.
patients that, because a lot of them are reaching to do dentistry, and in dental insurance is
Mm-hmm.
not
Reaching
insurance.
financially.
And yeah, it's not insurance, it's only
Mm.
payment assistance, and they may not cover what's really
Yeah.
needed. And so you have to help patients out a little bit. But if you have a plan, you can do that.
Yeah.
So that's what I try to do.
So it would help. Yeah. I mean, it would help, I think, for those of us who listening who aren't dentists to think through a couple scenarios. Because when I think about it, when I'm back in the Dallas area, you see billboards showing, before and after implant dentistry. And, there might be somebody who's an example of, they've just never gotten orthodontic work like my parents were able to pay for when I was a kid. Maybe they haven't taken good care of their teeth. So I don't know if it's a really crooked teeth and or a lot of decay. I mean, is there a situation where somebody's just full mouth of teeth is so bad? Is that a situation where implants might
Not
be the right
necessarily.
solution?
I've done full mouth cases
Really?
without
Okay.
implants. Before there were
Yeah.
implants, my dad did dentistry on the worst teeth you ever saw, and I could show miracles and how they worked. And most people have no idea that
Mm-hmm.
that's even possible. I know how, for example, to make a precision attachment case, and that's what I wrote my textbook on. And nobody knows anything about it.
Mm-hmm.
Invented in 1906, which is very unfair, and also works very well with implants.
Yeah.
And it's a type of removable where the front part usually is fixed. So let's say you were doing there's some front teeth, or you're going to put 3 implants in the front, and you can make fixed bridge work and a precision attachment partial denture to replace all the back teeth. And this functions differently from every other kind of case like this, because it doesn't grip or
Mm-hmm.
lock onto the abutment teeth. It It consists
Yeah.
of a male and a female, and the angle of how you take the removable in and out is tilted in two directions, and that direction is different from the pull of the muscles and gravity. And so if a stress is applied to
Yeah.
it, it can move slightly to relieve the stress, but it can't come out. And they're worn 24 hours a day. Nobody knows that you have it. They're only taken out for hygiene, and they last decades, better than any other kind of case by far. Because if you're looking
Hmm.
at all your cases or your patients when they come in for their hygiene visits, you find out really well what works, what lasts the longest, what works the best right away. And there are
Right.
thousands of these cases, and nobody knows anything about it. Very, very sad. A lot of I
Mm.
really believe,
Yeah.
that if we're going to advance as a profession, anything new that comes down the pike must be compared to the standard of what came before. Otherwise, you're not advancing.
Sure.
That is not being done
Yeah.
in my area of dentistry. And some of the new
Hmm.
technology actually violates the basic principles that allowed my dad and I had so much success with. Like, for example, crowns in an
Hmm.
hour. Okay, so it's everybody's impressed with the fact that this machine can mill out a crown right there, chair side, out of a block of
And
ceramic.
then you don't need a temporary, right?
Yes. However, what is that? Because all that matters is the end product, not how it was made. And the end product is
Hmm.
no different than the old high fusing porcelain crowns that were baked in an oven in the 1960s. You think we didn't know what was wrong with those? They can never be sealed, bacteria or microns. And that's
Hmm.
why I say
Hmm.
I make all my crowns with the mason jar cover effect, because that compensates for
Right.
the fact that we can't really see at the micron level or make dentistry with
Hmm.
accuracy at the micron level. And that compensates for that.
Yeah.
So that's the problem, that people are having crowns that fall out and that decay underneath. And if they require
Yeah.
re-cementing, they can leak and decay. That's the reason.
Hmm.
So I'm
Yeah.
against that. And the younger professionals have no idea where dentistry came from, so they are easy prey for these companies that want to sell their
Hmm.
$100,000 machine, and you have to make an awful lot of
Yeah.
these to pay for that, and it's a
Right.
waste.
Right. Wow. I don't know. Maybe I'm jumping to a solution here, Ed. Maybe you need to get on TikTok and try to find these young dentists, and
I
you know,
try, believe me.
um,
They hang out in
yeah,
Facebook a lot and in these groups, and
yeah,
I try to steer them over to the teaching website so that they could learn how to do
hmm,
crown and bridge. But it's very hard to convince them. It's very hard to reach them.
yeah,
A lot of times, I think they're just not interested, and that's sad. The fun
hmm,
of dentistry is trying to better yourself, the challenge of doing better, of
yeah,
watching your patient come in year after year, and the work that you did last in health. There's no better feeling than that. That's why I'm a dentist.
yeah, yeah. Well, and I appreciate that spirit, and there's that word practice and practicing. Dentists, doctors, attorneys, yoga students, like they use that word practice. And having worked in healthcare, I kind of picked up on that. And like a lot of the work I do as an engineer with an MBA is what's often called lean management. I wrote a book with some people years ago called Practicing Lean,
Yeah,
because it's that same idea. We should be continually learning and honing
that's
our
right.
craft. And if we make
Exactly.
mistakes, which I certainly did, this book is a precursor in a way to the My Favorite Mistake podcast, because it's people sharing their reflections of like what I didn't know or what I did wrong early in my career, but I learned from it. And some people maybe repeat the same mistakes their entire career.
Yes, that's
And
right.
that's not good for
That's
anybody.
that's sad, really, because whenever I make a mistake, I don't beat myself up. If something fails, I want to know why.
Hmm.
I want to learn from it, and they should be looked
Yeah.
at as learning opportunities, because we're human beings. We're not
Hmm.
robots, and so you have to also not be so hard on yourself. You have to look at things analytically and not emotionally.
Mhm.
And
Yeah.
that's common for all of us because we're working in such a small area. It's common for all of us to beat ourselves up inside when something goes wrong.
Yeah.
And that's not fair to do that. Like, for
Hmm.
example, okay,
Yeah.
uh, you know, taking impressions, when I take impressions of teeth, I take impressions of the entire root surface below the gum. And this is not taught because it's not so easy. There's a learning curve to develop that skill. And
Hmm.
once in a while, you're going to take an impression, and it's not coming out. And then the office manager comes in and aggravates you with something in the waiting room, or you're tired, and you can't see why you're not getting this impression. So I always tell everybody, this is kind of like doing crossword puzzles. Do you ever do like a crossword puzzle and you look at all the clues? I don't know anything. I can't fill this out. And then you put it
Yeah.
down and you come back an hour later and you're looking at it with a fresh pair of eyes. And now it's
Hmm.
obvious
Hmm.
and you fill in the entire thing. One, two, three. That is exactly what happened
Yeah.
with taking impressions. So if you're not getting it, send the patient home, have them come back. And usually I say, I set a lot of time aside. Oh my God, this is going to be really difficult. In 2 seconds, I
Yeah.
identify what the problem is, and then I'm done in 5 minutes. And now I have all this extra time. That's what always
Yeah.
happens. And I'm sure
Yeah.
that idea could apply to just about any endeavor that you would do. Something isn't
Yeah.
working, you know, close up or put it away,
Hmm.
come back another time when you have a fresh pair of
Yeah.
eyes and a fresh viewpoint, and then it'll be
Hmm.
obvious.
I think, you've written books, I've written books. Writing can be that way too. Sometimes you need to just set it down and
Oh,
come back and
yes.
look again.
What am I going to write about this week?
So one other question I want to ask maybe before we wrap up, Ed, and thank you for sharing, your perspectives on all of this. I was going to ask, maybe in these cases where implant dentistry is being done inappropriately, you know, there there could be all kinds of, I mean, people are paying out of pocket. There could be hard sell tactics, or I'm not saying everyone doing this would be doing that, but it seems like the type of thing, like, your local news has its I team. And you would hear, like, tonight at 11, dentists taking advantage of their patients. We investigate. Like, are there any news stories
Yeah, unfortunately,
like
yes.
that
I do
coming
not
out?
want to be a
And
whistleblower for
yeah,
my profession, but we have everything good, bad,
yeah.
and everything in between, like every other profession has. And that
Hmm.
pains me because up till
Yeah.
now, we've had a really good reputation. And this may not continue
Right.
if stuff like this happens often.
Yeah. Well, and there's a lot of trust people have in their dentist. Sometimes people see the same dentist for, it's a very, very, it can be a very long patient relationship. If I wasn't moving around the country, if I as I have so much as an adult, I mean, I saw the same dentist from probably second grade through graduating high school, and there's a relationship. You trust them, and I think your point is a really good one, that you wouldn't think, that, oh, well, why would I need a second opinion? All these dentists are equally good, or at least my dentist is as good as others. And like you said, there's good, bad, and ugly in any line of work, right?
Well, we're judged in a very superficial way by patients. And the criteria that they judge us on really have nothing to do with the work. Oh, he's got a nice office, or he gives a really good
He's
injection.
friendly, or
Yeah,
she, yeah,
that
yeah,
kind of stuff. That has nothing to do with the quality of the work. And patients are not really going to find
right,
out what they have no way of evaluating of what they're getting until, about 5 years. If I don't have my
uh,
dentistry last at least 10, I think it's a failure. But most dentists are happy to have five
hmm,
years because that insurance company will
hmm,
pay for a restoration. And I don't think that's right.
yeah,
I think we should strive for better than that.
yeah. And then one other last question, like the other thing you hear or see promotions for is, like, veneers. Is
Okay.
that something that's just like completely cosmetic?
Yes, it's cosmetic. Veneers are really suitable for young people, and the reason is that they really only bond well to the enamel layer, and you can't take that much
Hmm.
off of the tooth surface without putting back something that's bigger. A young person is going to
Hmm.
tolerate that well. But an older person who has the
Hmm.
beginnings of periodontal bone loss, that's just going to
Hmm.
increase the likelihood of periodontal bone loss. They should have crowns
Yeah.
because you can make the crowns ideal architecture, make them smaller, which you cannot do with veneers. It's more like a filling than it is changing like a crown would be changing the architecture completely. And everyone who has
Mm.
veneers is committed to doing crowns one day because the tooth structure has been cut. And when the dentistry needs to be
Hmm.
replaced, most likely veneers won't be the right treatment. However, in young
Hmm.
people, they have very large nerves inside the teeth, and they're more likely to get involved with root canal therapy with crown and bridge work. So veneers are actually
Hmm.
a good choice for them when cosmetics is an important
Hmm.
issue. So I'm not against them at
Yeah.
all. I think where they're appropriate,
Hmm.
they're excellent. And there are some people who
Yeah.
really excel at it. And if
Hmm.
somebody's really interested in, they should look for the person who can deliver the best results. Some of them are really excellent, and other people really, they do a case here or there, and they're not as good, and you're not as likely to get a really good cosmetic result. So, my suggestion would be to search out the person who specializes in that.
Yeah. And I think as we wrap up here, Ed, I mean, there's that general theme in what I hear you saying is that you're not opposed to any of these treatments. You're opposed to the inappropriate use.
Correct. Yeah, I've done a lot of implants,
Yeah.
so I'm not against implants. They're wonderful where they're
Hmm.
indicated. But I am now witnessing a lot of experimentation and things being done that don't make sense from you're an engineer from an engineering standpoint. They don't make sense, and that just sets you
Hmm.
up for failure, and it can be
Yeah.
really frustrating for the patient who shells out a lot of money to do this kind of work and then it doesn't hold up. And
Yeah.
I don't think that's right. So you have to pay very close
Right.
attention to what you can do from an engineering standpoint. And there's a famous dentist who recently passed away who said that the treatment of implants must be based on the management of biomechanical stress and anything that you can do to minimize the forces that are going to be acting on these things. Because implants are not like natural teeth. Natural teeth are connected to the bone with a ligament, and there's some give there, and a loose tooth can tighten up. But the implants is like sticking a nail in concrete. And when bone loss starts to happen around the implant, it never repairs. There's no periodontal ligament, there's no give there. There's the implant and the restoration have to take the brunt of the forces because there's no give. So anything you do has to take that into consideration and minimize the forces on these implants. That a lot of times that is not
Right.
being done. They're being stretched beyond what they can handle. I see that all the time, and I can size it up right away.
Hmm.
This is going to fail. This
Hmm.
can't work, and that's not
Yeah.
fair.
Mm. Well, Ed, it's been really interesting discussion. I'm going to keep going to my dentist and doing everything I can to keep my teeth and gums healthy. And appreciate you sharing, perspectives. If I or the listeners were in the situation of needing, restorative cosmetic dentistry, I guess do some research. Don't be afraid to ask for a second opinion. It seems to be one of the key takeaways.
Yes, and also prevention is everything. So the best means of
Hmm.
taking care of yourself is going regularly for hygiene, Because one of the things that
Yep.
we know causes bone loss is letting tartar and plaque and calculus build up that can cause the gums to become inflamed and spread to the underlying bone. And once the bone is lost, we
Yeah.
don't know how to grow it back. So prevention is everything.
Right. Yeah. Well, I appreciate you sharing all of that and all your mindsets about reacting to failure, learning from mistakes, great themes for this show, of course. So, again, our guest today, Dr. Edward Feinberg. The website is theonwardprogram.com. I'll put links to that and more in the show notes. So, Ed, thank you again. This has been really interesting. Thank you for being my guest.
Thank you. I think you were a terrific interviewer, and I really enjoyed it.
Okay. Thank you.